Bismillahirrahmanirrahim. Hello guys, and today our topic is about hyperkalemia. And you know that normal serum potassium is from 3.5 to 5.2 milliequivalents per liter. But if the amount of potassium increases more than 8 or 7 or 5 or 6, it can result in hyperkalemia. But why I'm mentioning specifically 8? Because if the amount of potassium is more than 8 milliequivalents per liter, it can contribute to the development of diastolic arrest. Okay, and diastolic arrest can lead to death. Okay, it can directly lead to death because it's very dangerous kind of arrhythmia that happen inside the heart. So what are the etiology and what are the causes for the development of hyperkalemia? So first of all, we will look into the causes and then we'll talk about the treatments. First etiology is known as the lab error. It can be due to lab error, some technical errors, or due to the error of the patient, and we also called it as the pseudo hyperkalemia. It's pseudo hyperkalemia. In real, there is no hyperkalemia, but due to the lab error, we are having an increase in serum potassium. But why is that so? First is the clenching. Fist clenching during the withdrawal of the blood. Fist clenching can lead to pseudo hyperkalemia. The second is the narrow bore needle. When the needle is very narrow bore needle can also contribute to the development of hyperkalemia because it will cause the destruction of RBCs. RBCs will be destructed and it can alter the calculated amount of potassium. Destruction of RBCs. And other lab error, it can be the cooling of sample. Cooling of sample, the nurse may have put the sample in a refrigerator, right? So cooling of sample can also alter our results. The next is the increased amount of leukocytes. Okay. Total leukocyte count is increased or the total platelets are increased in the blood. They can also alter our calculations of the serum potassium platelets. Okay, so this is the pseudo hyperkalemia, the fist clenching during the withdrawal of the blood. It can be narrow bore needle, there can be cooling of the sample, or total leukocyte counts can be increased, or total platelets can also hinder the amount of the potassium. The second are the kidney diseases like chronic kidney disease or acute kidney injury. We can also mention acute kidney injury because these conditions cannot excrete the potassium well because tubules are not functioning well. That's why the chronic kidney disease is occurring. So in case of chronic kidney disease or acute kidney injury, there will be less excretion of potassium, and potassium starts to build up inside the cell and it results in hyperkalemic conditions. The next etiology is hypoaldosteronism. It's hypoaldosteronism because the function of aldosterone hormone is to reabsorb sodium along with water and in turn the excretion of potassium and hydrogen. But when aldosterone is in deficient amount, it results in the build up of potassium inside the blood. What are the conditions that leads to hypoaldosteronism? First is the Addison's disease. Addison's disease is also known as hypoaldosteronism because in case of Addison's disease there is the damage of the adrenal glands, and when the adrenal glands are damaged, from the cortex of the adrenal gland the aldosterone is being produced. So when Addison's disease, the adrenal gland is damaged, so how the aldosterone is going to be produced? It will result in hypoaldosteronism. The second condition is histoplasmosis. histoplasmosis is a fungal infection. Okay, histoplasmosis, it's a fungal infection and it can also damage the adrenal glands, right? And the third is the HIV. HIV can also cause hypoaldosteronism because HIV is related to AIDS and it's overall immune deficient conditions, right? So it can damage the adrenal glands. The last but not the least that cause hypoaldosteronism is known as the water. It's like a fancy name, Waterhouse. It's Waterhouse. Fred, I hope the spellings are correct. It's Frederickson syndrome. Waterhouse-Friderichsen syndrome is also a condition that causes bilateral adrenal hemorrhage. It's a very dangerous condition because it causes bilateral adrenal bleeding. It causes bilateral adrenal hemorrhage or bleeding. So, in case of bleeding of the adrenal glands, they are not functioning properly, so amount of aldosterone inside the blood will decrease. And when aldosterone is reduced, let me draw the most classical diagram. Here is the sodium epithelial channels. Sodium epithelial channels. So aldosterone function is to reabsorb sodium along with water, right? It will reabsorb sodium along with water and then it will excrete the potassium and hydrogen. But when there is no aldosteronism, there will be no sodium water reabsorption, there will be no potassium hydrogen excretion. It will cause hyperkalemia, it will cause acidosis because hydrogen ions are built up inside the cell. So but in case of there is a condition known as the Gordon syndrome. Gordon syndrome does not cause hypoaldosteronism. Let me explain that. Gordon syndrome is a condition in which there is the gain of the function of, let me write that, there is gain of function of sodium chloride. There is a sodium chloride cotransporter in the distal convoluted tubule. It is opposite to the Gitelman syndrome because in case of Gitelman syndrome, this sodium chloride cotransporter was inhibited or dysfunctioned. But in case of Gordon syndrome, there will be increased function of the sodium chloride cotransporter. What does it mean? What are the manifestations of the Gordon syndrome and how it's going to cause hyperkalemia? Because there is a gain of function of sodium chloride, so it will reabsorb more sodium, okay, and water. It will reabsorb more sodium and water and it result in hypertension. First manifestation has been discussed. The second is that due to the reabsorption of sodium in the distal convoluted tubules, so there will be less amount of sodium reaching the collecting ducts, right? So in the collecting duct where the aldosterone is going to function, there will be low reabsorption of sodium and subsequently there will be less excretion of potassium and less excretion of hydrogen. What does it mean? It means that a lot of sodium has already been reabsorbed in the distal convoluted tubule and less amount of sodium reaches the collecting ducts, right? And subsequently there will be less sodium reabsorption by the aldosterone and less potassium and hydrogen excretion. So first manifestation is hypertension. The second manifestation is hyperkalemia because potassium is not excreted. It will build up inside the blood and hydrogen will also build up inside the blood. It's known as the metabolic acidotic conditions. And Gordon syndrome is also known as pseudo, let me write the full name, it's pseudo hypoaldosteronism, pseudo hypoaldosteronism type 2. Okay, because In this condition, the serum aldosterone may be normal, but due to the manifestations of Gordon syndrome, we are having manifestations that aldosterone is deficient, but it's pseudo hypoaldosteronism. Although the amount of aldosterone is normal inside the blood, but due to the gain of function of sodium chloride and less amount of sodium reabsorption in distal part of the nephron and less potassium and hydrogen excretion, we are having the manifestations that the aldosterone is deficient, but it's not in the real. Let's talk about the workup for such patients. Workup for the patients of hyperkalemia can be, first of all, we need to check the serum potassium, and when we check the serum potassium is elevated. It's very logical, right? And the we need to look at the ECG of such patients. The ECG findings would be opposite to that of hypokalemia. Okay, in case of hypokalemia, we have discussed that there will be depression of T wave, but in case of hyperkalemia, there will be tall tented T waves. There will be tall T waves. Okay. In case of hypokalemia, we have discussed that there will be peaked P waves, but in case of hyperkalemia, P waves would be decreased. The P wave height is decreased, and more specifically, this happens when the serum potassium increases more than 7 milliequivalents per liter. Okay. The next finding is that there will be ST segment elevation, because in case of hypokalemia there was ST segment depression. In case of hyperkalemia there will be ST segment elevation. Last but not the least, there will be broad QRS. There will be broad QRS. It's like the very most important finding that we can find in the ECG. And another very life-threatening emergency condition is known as the sine wave pattern. It's sine wave pattern. Sine wave pattern is very classical because it happens when the serum potassium increases more than 8 milliequivalents per liter, and this sine wave pattern is life-threatening emergency condition, and we have talked that when the serum potassium is more than 8, there is a risk of diastolic arrest, and ultimately the death will result of the patient diastolic arrest. Okay, and talking about the treatment of the hyperkalemia, there are like specific ways that we can treat the patients of hyperkalemia. First of all, the treatment will lie in antagonizing the effects of potassium. What does it mean? First strategy is that we can antagonize the effect of potassium. Antagonize effect of potassium, right? Potassium is a relaxant. Potassium relaxes the blood vessel. It relaxes the smooth muscles. But what contracts the smooth muscles and what contracts the muscles? It is calcium. So calcium gluconate. First is the calcium gluconate. Calcium gluconate. It antagonizes the effect of potassium. The second is the calcium chloride, and third one is the calcium carbonate. And there is a twist, I will tell you. Calcium carbonate is not used. Calcium carbonate is not used, but calcium gluconate and calcium chloride antagonize the effect of potassium. Potassium relaxes the blood vessels, relaxes the smooth muscles. Calcium contracts the blood vessel, it contracts the smooth muscle. So calcium gluconate, calcium chloride, and calcium bicarb are very helpful. The second strategy we can apply here is to redistribute the potassium. It's redistribute the potassium, right? So if the amount of potassium in the serum is high, we can just redistribute it and the serum potassium will become low. The first strategy in redistributing the potassium is insulin drip. It's insulin drip plus 50% dextrose. 50% dextrose. Okay? Because as you know that insulin causes the potassium to move inside the cells, but in addition to causing that, insulin also cause hypoglycemia because it also causes glucose to shift inside the cell. It causes hypoglycemia. That's exactly why we are giving 50% dextrose along with the insulin drip. The second strategy in redistributing the potassium is salbutamol nebulizer. Because salbutamol is a drug, it is a beta 2 agonist and it is also used in treating the asthma because it causes bronchodilation. But in case of hyperkalemia, salbutamol causes potassium shift into the cell. Potassium shift into cells, and that exactly what we need in case of redistribution. Its dose is 4 times higher than in asthma. In case of hyperkalemia, the dose of salbutamol is 4 times more than in the asthma. Last strategy that we can apply in case of treatment is known as the removal of potassium. Removal of potassium either by urine or by the GI route, urine or GI, removal of the potassium. So what are the substances or molecules that aid in removing the potassium? First is the furosemide. You all know that furosemide is a loop diuretic, and loop diuretics are very important in causing polyuria, right? So it's loop diuretic because it blocks the, what is the function of furosemide more specifically? It blocks the sodium potassium 2 chloride co-transporter in the ascending limb of loop of Henle, thick part, right? When it is blocked, sodium cannot be reabsorbed, potassium cannot be reabsorbed, chloride cannot be reabsorbed, and they will drain into the urine along with the potassium, so there will be kaliuresis, and that what we needed, right? Kaliuresis. The second molecule that aid is known as the sodium polystyrene polystyrene sulfonate. Sodium polystyrene sulfonate, and it is a resin, right? It is a resin that will cause fecal loss of potassium. It's a resin, but studies have shown that this sodium polystyrene sulfonate is notorious to cause GI necrosis, and we do not want our patient to have GI necrosis in the management of hyperkalemia. So it's not used like normally, but we can use if there is dangerous type of hyperkalemia. The next molecule that will cause removing of potassium is patyromer. It's Patty Romer is also known as by the brand name known as the K-bind. It's K-bind. It is a potassium binder and it will cause the fecal loss of potassium because in case of intestine it will inhibit the absorption of potassium because it is binding to that. How it's gonna be absorbed in the intestine. The next molecule is ZS9. The ZS9 is very useful. The full name is known as the sodium zirconate. It's sodium zirconate cyclosilicate. Cyclosilicate. And it is also a potassium binder. It will cause the GI loss of potassium by binding to the potassium and it will inhibit the absorption. But again here bicarbonate. Sodium bicarbonate is not used in case of removing the potassium. It's not used. Sodium bicarbonate is not used, and in the antagonizing strategies, calcium carbonate is not used. Just these are some exceptions that you need to remember. One more thing is that we have talked about ECG, right? ECG, there will be tall tented T waves, the height of the P wave will decrease, there will be ST elevation, broad QRS, and sine wave pattern in case of dangerous hyperkalemia. But the ECG findings are not always accurate test for estimation any electrolyte imbalance. We should always go for other workups like serum management of the electrolytes, or we can check the urinary electrolyte panel, right? So ECG isn't always the accurate one in diagnosing the electrolyte imbalances. This was for today. I hope you understand the lecture, and in the next video we'll talk about calcium